Hello students, I am Dr. Arpit Aggarwal and today we will be discussing the pharmacology questions based on the recall from the NEET 2020. So let's start with the question number 1. It says that theophylline causes diuresis because of. The answer to this particular question would be option number B, that is adenosine receptor antagonism. Now let's look at the relevant discussion. Now theophylline, as we all know, is a bronchodilator used in asthma mainly. It has three mechanisms of action. Number one mechanism of theophylline, it will inhibit the enzyme phosphodiesterase. PDE stands for phosphodiesterase. This enzyme breaks down cyclic AMP. So by inhibiting this enzyme phosphodiesterase, theophylline would lead to increase in the level of cyclic AMP. Cyclic AMP would increase. This is the number one mechanism of theophylline, phosphodiesterase inhibition. Now, it is a non-specific inhibitor. That is the word to remember. Non-specific. There are multiple types of phosphodiesterase in our body, and theophylline is not specific for any one subtype of phosphodiesterase. So, option number 1, that is phosphodiesterase 4 inhibition, or option number D, phosphodiesterase 3 inhibition can be ruled out because theophylline is a non-specific phosphodiesterase inhibitor. So that is the number one mechanism of theophylline. The second mechanism of theophylline is adenosine antagonism. So adenosine is another bronchoconstrictor in our body. So adenosine acting on adenosine type 1 receptor and type 2 receptor causes bronchoconstriction, and by antagonizing those receptor, theophylline is able to cause bronchodilation. So these are two mechanisms of the bronchodilator action of theophylline. Bronchodilator, phosphodiesterase inhibition, non-specific, and adenosine receptor antagonism. Now besides these two bronchodilator mechanisms, theophylline has one more mechanisms, that is it activates an enzyme known as histone deacetylase, HDAC. HDAC stands for histone deacetylase. So theophylline activates histone deacetylase, and activation of histone deacetylase, it will inhibit inflammatory genes. So theophylline is also able to inhibit inflammatory genes, and that contributes to its anti-inflammatory action in asthma. So these are two mechanisms of theophylline in asthma, but the question is asking if it is able to cause diuresis, and yes, then how so? So as I have indicated, the mechanism will be adenosine receptor antagonism. So we have to further focus on the mechanism number 2, adenosine antagonism. Now, adenosine is an important neurotransmitter in our body, and it is involved in several functions in our body. Now, what are those functions? If we take them one by one, number 1, adenosine is a CNS depressant. It causes sedation, it's a CNS depression. So any drug which is adenosine antagonist will be able to cause CNS activation, and that is why drugs like theophylline or caffeine, remember theophylline belongs to the same class of molecules as caffeine, they are able to cause CNS activation. So anything that is adenosine antagonist will cause CNS activation, and that is one more effect of theophylline by opposing adenosine. Second, adenosine reduces glomerular blood flow. It causes vasoconstriction in the pre-glomerular capillaries, and that reduces glomerular blood flow. So by opposing adenosine, theophylline is able to increase glomerular blood flow, and that results in diuresis. that results in diuresis, which is what the question is asking. So by opposing adenosine receptor, theophylline is able to cause diuresis. Third important mechanism of adenosine is, if you will recall, adenosine is drug of choice for PSVT, paroxysmal supraventricular tachycardia, and what it does, it causes hyperpolarization of AV node. So adenosine causes hyperpolarization of AV node that decreases number of impulses which are passing from atria to ventricle, and that is helpful in the treatment of PSVT. But hyperpolarization of AV node would result in bradycardia. So any drug which is opposing adenosine like theophylline can cause tachycardia. Now why we are discussing this? Because this year they have asked one particular property of adenosine and the action of theophylline on that, that is diuresis. Adenosine decreases glomerular blood flow. So by opposing adenosine, theophylline is able to cause diuresis. Okay. Besides this, adenosine is a bronchoconstrictor. So by opposing adenosine, theophylline is able to cause bronchodilation. But there are two more effects of adenosine which theophylline will oppose. Adenosine, as I've told you, is a CNS depressant. So by inhibiting or opposing adenosine, theophylline causes CNS activation, and that is why in theophylline toxicity there are seizures. So tomorrow this property can be asked, that seizure also has a role of adenosine antagonism. And secondly, adenosine is causing hyperpolarization of AV node. This property makes it useful in PSVT, but by opposing adenosine receptor, theophylline can cause tachycardia, and that results in arrhythmia in theophylline toxicity. So that is why these actions of adenosine, which sometimes contribute to theophylline action, but at the same time sometimes theophylline antagonism can be harmful. So this is what this question is all about. This year they have asked a relatively non-important result of theophylline antagonism, diuresis, but maybe next year the CNS activation resulting in seizure or heart rate increase resulting in arrhythmia may be asked. Second question is a pretty straightforward question. Which of the following is not a prokinetic? So what is a prokinetic drug? We all know prokinetic drug is a drug that increases gastric emptying, that relaxes pylorus, and that increases the tone of lower esophageal sphincter. So 3 points are essential for a drug to be called prokinetic. Basically, it will increase the gastric emptying, so gastric content will move faster into the intestine. So pylorus has to be relaxed and the lower esophageal sphincter has to be constricted so that its tone increases and the gastric content do not regurgitate. Now, which drugs are prokinetics? Number 1, blockade of D2 receptor. Blockade of D2 receptor in GIT causes prokinesis, and that should remind us of two important drugs, metoclopramide and domperidone. These two drugs are prokinetic. Mechanism is blockade of D2 receptor. The second type of drugs are 5-HT4 agonist. 5-HT4 agonist, and the drugs are cisapride like drugs, and another one is tegaserod and cisapride. The third class of drugs which are mentioned in the options could be motilin receptor agonist. Drugs that will stimulate motilin receptor, as the name itself suggests, it will increase motility, and these drugs are drugs like macrolides. Antibiotics like erythromycins, which belong to the class macrolides, they can also stimulate motility. So these are the three classes of drugs that can be classified as prokinetics, increasing gastric motility. So the answer which is not a prokinetic will be the option number D, diphenoxymethane. Okay, so the answer to this question is option number D, 5-HT4 agonists, D2 blockers and macrolides, they are prokinetic drugs. Now important point to remember in these classes of drugs, metoclopramide and domperidone, they have no action on colonic motility. Please remember. So this point is very frequently asked. The first D2 blockers type of drug will not affect colonic motility, while the 5-HT4 agonist, they will also increase colon motility along with the stomach and the small intestine motility. So that is one very commonly asked point or difference in D2 blockers versus 5-HT4 agonist. Which drug will also affect colonic motility? It is the 5-HT4 agonist. Moving to the next question, mechanism of resistance to penicillin via beta lactamase. This is, I think, a question as simple as it can be. So penicillins are beta lactam ring, and beta lactamase, as the name enzyme, is an enzyme which will break open the beta lactam ring. So the answer will be breaks drug structure. Now what are the points that we should know in this particular question? So you see, penicillins are beta lactam antibiotic. What does it mean? So there is a 4-membered ring. Beta lactam is a 4-membered ring. It has carbon all along with nitrogen here, carbon here, and a double bond with oxygen. This is a beta lactam ring. Now all beta lactam antibiotics have a beta lactam ring. Now along with that, there can be an adjacent 5-membered ring attached to it, which can be called as a thiazolidine ring. Now this ring may be present in penicillins, cephalosporins and carbapenems, but this thiazolidine ring is not present in monobactam. But we don't know the significance of this ring, so let's not focus on that. So any drug which has a beta lactam ring is a beta lactam antibiotic. Now what question you are asked is that beta lactamase will break open this ring, so that we understand. But sometimes you are given option number A shown like this, option number B, option number C and option number D. And what you are asked in an image based question is that out of A, B, C and D, which bond will be broken by beta lactamase enzyme. So this is one of the image based questions which can be asked in relation to the same question that we are discussing. So we have to remember that it is the bond number A, bond shown by the option A, which is broken by the beta lactamase enzyme. Beta lactamase breaks this particular bond. So that you have to remember as a further addition to this particular question, that beta lactamase obviously will break the beta lactam ring, and the bond shown by option number A is the bond broken by beta lactamase. Answer to this particular question will be option number C, breaks drug structure. If we look at some of the other options, altered penicillin binding proteins. So penicillin binding proteins, mainly transpeptidase enzyme, can be altered, and this is the mechanism of resistance in methicillin resistant staph aureus, MRSA. So MRSA becomes resistant to penicillin by penicillin binding protein mutation. Drug efflux is the most important mechanism in tetracyclines. Tetracycline, including tigacycline, drug efflux is the most important mechanism. Alteration in 50S ribosome structure could be responsible for resistance in antibiotics which are binding to 50S ribosome, like macrolides, like sometimes even chloramphenicol. So moving to the next question, fluoroquinolones contraindicated in liver disease. Now this is slightly a controversial question, because in general fluoroquinolones have no significant hepatotoxicity. The only fluoroquinolone that had significant liver toxicity and that was banned because of it was trovafloxacin. So Trovafloxacin. Trovafloxacin was withdrawn from the market because of significant hepatotoxicity. So if that was given in the option, then this would have been the answer. But we do not have trovafloxacin. So now, assuming that this is a correct recall question, we are trying to find out the best out of the given. So when we look at the option, P-floxacin is what may come to our mind, because the dose of P-floxacin is to be reduced in liver failure, but it is not contraindicated in liver disease. So that is not the option. Then further literature search reveals that there are two more fluoroquinolones that have been recently implicated in causing liver problems and should be avoided in patients of liver disease. What are those two? One is moxifloxacin. So moxifloxacin should be avoided in patients with acute liver disease, but again moxi is not given in the question. Then the next is levofloxacin. Levofloxacin should also be avoided in patients of liver disease. So in this order, trovafloxacin being considered the most hepatotoxic, followed by moxi, followed by levo, we will look for the answers to this question, and we find that levofloxacin is given. So for this question, amongst the option provided, the best answer would be levofloxacin. But had the option mentioned trovafloxacin, that would have been the answer. Moving to question number 5. A patient of biliary colic. Now, the moment we hear biliary colic, one of the very important point, even from an undergraduate perspective, comes to our mind, that do not give morphine to this patient. Let's see if the question is going in that direction. So, patient of biliary colic presented to hospital, in turn gave him an injection and the pain worsened. Which of the following is the most likely injection? I think even a second MBBS student should be able to answer this particular question. The answer is morphine. Why morphine should not be given to a patient of biliary colic? Because it increases or it causes increased contraction of the biliary sphincter, or what we call as the sphincter of Oddi. So increased contraction of biliary sphincter or sphincter of Oddi is a property of morphine, and that would worsen the pain of biliary colic. So morphine should be avoided or contraindicated in patients of biliary colic. And if we widen the indication a bit clinically, then in any patient of undiagnosed abdominal pain. So patient presenting with abdominal pain, and we have not yet made the diagnosis what is cause of the abdominal pain. So till that time biliary colic is a possibility, and therefore the patient should not be given injection of morphine in undiagnosed abdominal pain or a confirmed case of biliary colic, because it causes increased contraction of sphincter of Oddi. So that's a very simple question. Looking at the other options, diclofenac is a non-selective COX inhibitor, NSAID what we call it. Etoricoxib is a selective COX-2 inhibitor. So these three drugs A, B and C we know. Option number C is pretty interesting. Nefopam. What is this Nefopam? This is not a very commonly used analgesic, and if it has been put in the option this time, maybe we could have a question on Nefopam next time. So Nefopam should be understood. Again, this is an analgesic but a different one. It is a triple. It's a triple reuptake inhibitor. So triple reuptake inhibitor, what does it mean? This drug will inhibit reuptake of three substances: serotonin, noradrenaline and also dopamine. So it will inhibit the reuptake of three substances: serotonin, noradrenaline and dopamine. So we can call it serotonin norepinephrine dopamine reuptake inhibitor, SNDRI. So this is the important mechanism of nociception of nefopam, that it is a triple reuptake inhibitor. Along with that, nefopam also modulates, it will also modulate glutamate transmission. Glutamate, remember, is an excitotoxin, so that glutamate transmission will also be decreased or modulated by nefopam. So it has got two mechanisms, triple reuptake inhibitor and modulates glutamate transmission. So that is about nefopam, used as an oral analgesic. The answer to the question that was asked was very simple, morphine, and that we have already discussed. Moving to the next question, a patient with diabetes and COPD developed post-operative urinary retention. Which of the following drugs can be used for short-term treatment to relieve the symptoms of this person? On the first look, this question seems like a very simple question. Patient has post-operative urinary retention. What is to be done? Generally, the answer is bethanicol, and that is what most people would like to think of. So what does bethanicol do? Let's look at this particular drug first of all. So we have the urinary bladder. The body of bladder is formed by the detrusor muscle. So this is detrusor muscle. Now the detrusor muscle has got muscarinic receptors. So there is muscarinic receptor on detrusor. This is the bladder sphincter. Okay, this is the bladder sphincter. The patient has developed what we call as the post-operative urinary retention. Post-operative urinary retention, in short referred in surgery as POUR. Post-operative urinary retention has been developed. Normally, what is the treatment suggested? We just stimulate this muscarinic receptor by giving a cholinergic drugs like bethanicol. If there is no obstruction, please remember, the word to remember is no obstruction in the outlet, then bethanicol or any cholinergic drug acting on muscarinic receptor will contract the detrusor and urine will come out very easily. Urine will come out very easily, but there should not be any obstruction in the outlet, which is not present in the case, so we can think of bethanicol. But if we look at the question, the patient has been having history of diabetes and COPD, so we should ask why these 2 points have been mentioned. Is it just to confuse you, or they have some clinical relevance out there? So diabetes, history of diabetes may lead to neuropathy, and such patients are at increased risk of post-op urinary retention. So we can think of that the examiner is trying to give us a clinical scenario. In these kind of patients, post-operative urinary retention is frequent or more common. Why COPD? So if COPD was not given in this question, then bethanicol would have been the answer, no doubt. But the history of COPD makes me think that the second option is methacholine. Methacholine is a similar directly acting muscarinic drug, directly acting cholinergic ester like bethanicol, and methacholine should remind us of methacholine challenge test, which is used for diagnosis of bronchoconstriction or particularly asthma. Similarly, bethanicol is also a cholinergic drug acting on muscarinic receptor, and this can also cause bronchospasm. Bronchospasm is a frequent side effect by acting on muscarinic receptor on lungs. So all the books mention that bethanicol is capable of causing bronchospasm, and bronchospasm may not be such a desirable feature in a patient with history of COPD. So then if we keep this point in mind and then look at the other option, then we find that tamsulosin. Tamsulosin we have so far discussed mostly in treatment of BPH, that it relaxes prostatic muscle and that is beneficial in treatment of BPH. But on further literature search, that it has been also used nowadays in treatment of post-operative urinary retention. So there are several articles available on internet, including one study that was conducted by AIMS, which has shown that tamsulosin is also beneficial by blocking alpha 1 A receptor which are present on bladder sphincter. So blockade of these alpha 1 A receptor by tamsulosin also helps in increasing the urine output, and this property has been tested in several studies, and tamsulosin has been found to be safe and effective drug for postoperative urinary retention. So considering all these points, that patient has had a history of COPD, tamsulosin has been provided as one of the option. I am more inclined to mark tamsulosin as the correct answer in this particular question. If the history of COPD suppose was not given, then I would be inclined to mark Bethanycol. So in the current format, I would say option number D is a better choice than option number A. Okay, so if COPD is not given, then Bethanycol we have been teaching, but since COPD history is given, maybe we want to avoid bronchospasm possibility, and that's why tamsulosin could be a better option. And there are supporting evidence for tamsulosin if we do a literature search on the internet. So this is about question number 6. Moving to question number 7, a female patient on lithium therapy for bipolar disorders for 6 months. Now, she kept the fast for few days due to religious reasons and presented with seizure coarse tremor. The moment we hear of coarse tremor, it should ring a bell in a patient who is on lithium. So lithium, if we talk about the lithium, then we all know it has a drug which has narrow therapeutic index. The most common problem to start with is the fine tremor. So the initial problem is fine tremor, the most common problem, but if we develop, or if a patient develops lithium toxicity, then the fine tremors convert into coarse tremor. So coarse tremor should raise a suspicion of lithium toxicity. Along with that, there is seizure, confusion and weakness of limbs. So there is neurotoxicity, which again confirm or our suspicion of lithium toxicity. Which could be the reason, which of the following should be done to diagnose her condition? Since I have been telling you lithium, coarse tremor and neurotoxicity, we are thinking of lithium toxicity. Serum lithium levels is the diagnosis, that is the investigation of choice for diagnosing this particular patient, serum lithium levels. So most probably this female patient has developed lithium toxicity. Now why that is so? So this is pretty common, and there are several search reports available for this. Patient is on lithium therapy. Now it is very simple. Lithium is excreted unchanged by kidney. It has renal elimination. It is excreted unchanged by kidney, and kidney handles lithium like sodium. So 3 points: lithium goes out of the body unchanged in urine, and kidney is going to handle lithium like sodium. Both are positively charged small cation. So this is how kidney handles lithium like sodium. So any situation where there is reduction in blood going into glomerulus. So if there is reduction in glomerular filtration rate, any situation that results in glomerular filtration rate, what happens to sodium in PCT? So whenever there is fall in GFR, there is increased sodium reabsorption, which happens in proximal convoluted tubule. So that we all know that whenever GFR will fall, the kidney would try to reabsorb more sodium from PCT, and along with sodium more water will come, and that would increase the plasma volume, and that could further benefit the falling GFR. So that's a common mechanism. Now whenever GFR will fall, sodium reabsorption from PCT will increase, and we are saying that lithium is handled like kidney. So that means that would also result in increased lithium reabsorption, and that could result in lithium toxicity. This could result in lithium toxicity. So that we understand. Now all we need to understand, what could be the simple possible reasons for fall in GFR. So number 1 could be dehydration. And dehydration could result because of excessive standing in heat, or it could also result because of fasting. So we understand during fasting, dehydration, loss of not sufficient intake of water could result in GFR, and that could result in lithium toxicity. That is what has happened in this female patient. Religious reasons, why this religious reasons word has been written. What does examiner want us to remember? Examiner wants us to remember that this is a possibility during fasting, prolonged fasting kept in the holy month of Ramadan. So there are several research reports available which have tested the effect of chronic fasting in the holy month of Ramzan and the patients who are on lithium therapy. So we should remember that this is a possibility, that due to dehydration there could be reduction in GFR that could result in increased sodium reabsorption. Along with sodium, more lithium can be reabsorbed, and that could result in lithium toxicity. So that is what has happened. Coarse tremor is an important sign, in fact the first sign of patient developing lithium toxicity. Now what else should we know? Lithium toxicity, what blood levels of lithium should we keep in mind? So remember, mild toxicity of lithium 1.5 to 2.5 milli equivalent per liter, mild toxicity. Then moderate, you just increase by 1, 2.5 to 3.5 milli equivalent per liter, and above than that there would be severe toxicity. Severe toxicity will result when the serum lithium levels, severe toxicity would result when serum lithium levels go above 3.5. Okay, so that you will have to perform hemodialysis. Hemodialysis, the cutoff level which is usually taken is blood levels above 4 milli equivalent per liter. So there is no specific antagonist or antidote to lithium toxicity. Hemodialysis or osmotic diuresis is what you can do. So symptomatic treatment is there. So we have to be aware of this possibility. Coming to next question, which of the following is used as nail lacquer? Again, students have got it wrong. Fungal infections, sometimes in some of the recall based they have specified that this is onychomycosis. So we don't know exactly what was asked, but whether it is fungal infection in general or onychomycosis, the word here is nail lacquer. Nail lacquer, that we have to understand. So nail lacquer in simple language is a nail polish. In layman's term, it is a nail polish. So it's a solution to be applied on nail lacquer, and that has a special property of increasing the penetration into the nail. So that is nail lacquer. So it's a nail preparation. So which of the following is available as nail lacquer or nail polish for treating fungal infection? So you see, out of the given options, let's look at them one by one. Fluconazole. Fluconazole is an oral drug. It's not a topical drug, it's an oral drug, and so is itraconazole. So they both are oral, so they are out of the options. We are left with terbinafine and cyclopyrox. So B and D, these two options are left. Now terbinafine is available oral as well as topical, but there is no specific nail lacquer, nail polish of terbinafine is not available. So then we are left with only one drug, cyclopyrox, that will be the answer to this particular question, cyclopyrox. So cyclopyrox, number one, and second is a drug known as oralofin. Oralofin. These two drugs are available as nail lacquer. So cyclopyrox, olamin, and oralofin, another drug. Remember, this oralofin is not a terbinafine like drug, it's a different drug. Both are available as nail lacquer or nail polish. So this will be the answer to this particular question. If suppose the word in fact of instead of fungal infection onychomycosis was written, then we should also look at the treatment of onychomycosis. So you see, onycho means nail, mycosis. So it's a dermatophytosis affecting nails, onychomycosis. Now there are two kinds of treatment available for onychomycosis. One is the systemic or the oral drugs. In the systemic or the oral drug, remember the drug of choice is terbinafine. So terbinafine is the best drug of choice, the first line drug for treatment of onychomycosis, but this is given oral. If terbinafine is not available, then the next option are itraconazole, or the third option would be griseofulvin. So these are the three oral options, out of which terbinafine definitely is the best drug. Now there are some others topical drugs which have also been asked recently and available for treatment of onychomycosis. So what are these topical? So in the topical applications, we can have a drug that was recently asked, I think a year back, ifinaconazole. So ifinaconazole is also available as a topical solution, and tevaborole. So these are two topical drugs which are available for treatment of onychomycosis, but again remember their topical preparation is not nail lacquer. They are also not specially nail lacquer. If the question asks nail lacquer only, then answer will be only one of these two, cyclopyrox or oralufin. Otherwise, topically ifenaconazole or tevaborole, they are solutions which can be also applied. So I think in this question there are two things that student has to consider. Number one, he has to arrive at the drug effective in a particular condition, and secondly, which type of formulation is asked. Okay, so this is the first time they have emphasized on the word nail lacquer. Question number 9 is a straightforward question. Which of the following drugs act by inhibiting transcription of DNA to RNA? So if we understand the process, DNA has to give rise to an RNA. RNA has to be formed. Obviously the enzyme has to be RNA polymerase. RNA polymerase is the enzyme which will form RNA. Now, so we are being simply asked which drug is an inhibitor of RNA polymerase. Which drugs are inhibitor of RNA polymerase? Rifamycin and fidaxomicin. These are the two important types of drugs. Rifamycin, which include all rifampicin, rifabutin, all RIF drugs. Rifampicin, rifabutin, rifapentin all come under rifamycins, and the second drug is fidaxomicin. These are two drugs which mainly act on RNA polymerase. So they will inhibit the transcription of DNA to RNA. So option number A, rifampicin, is the correct answer to this particular question. Looking at the other options, nitrofurantoin, it causes free radical damage to DNA. It, as the name suggests, nitro, it has a nitro group which is oxidized in the body, releasing free radicals, and they cause damage to DNA. So this affects DNA, not RNA. Ciprofloxacin and novobiocin. Now this is very interesting. Ciprofloxacin and novobiocin. Now most of the students know that ciprofloxacin is a DNA gyrase inhibitor. But what students frequently do not know, that novobiocin is another drug, another antibiotic which also inhibits DNA gyrase. So ciprofloxacin belonging to fluoroquinolones and novobiocin, which is totally a different antibiotic, both inhibit DNA gyrase, so they will inhibit DNA replication. Nitrofurantoin will cause free radical damage to DNA, and rifampicin is the drug that will prevent RNA synthesis by inhibiting RNA polymerase, along with another possible option, fidaxomicin. Question number 10, pegloticase is used in the treatment of, answer is chronic tophaceous gout. Chronic gout or chronic tophi, the subcutaneous deposit of urate crystals known as tophi, and that kind of gout we can use pegloticase. So what is pegloticase? So there was a discovery that was made that, I'll start from the very beginning. So you see what happens. Hypoxanthine can be oxidized to xanthine, and this can be oxidized to uric acid. So this is how uric acid is formed in our body. Hypoxanthine converted into xanthine and xanthine going into uric acid. The enzyme at both the places is the same, xanthine oxidase enzyme, xanthine oxidase. So this process stops at uric acid synthesis in humans, and uric acid, whatever can be excreted in urine, is done, but the process stops here. We can inhibit this enzyme xanthine oxidase. This can be inhibited by either allopurinol, or there is a new drug known as febuxostat, xanthine oxidase stat inhibitor. So these two drugs inhibit xanthine oxidase. So this is what we use in chronic gout mainly, allopurinol or febuxostat. Now there was a discovery that was made that uric acid can be converted into a substance known as allantoin. Uric acid can be converted into a substance known as allantoin by an enzyme known as uricase. Uricase enzyme. Now this uricase enzyme is not present in humans, this is present in birds. This is present in birds. And what is the significance of allantoin? That allantoin has a much more water solubility than uric acid. So it can be freely soluble in water and easily excreted. So if birds can convert uric acid into allantoin, they need enzyme uricase. We as humans do not have this enzyme, but once this discovery was made, we decided that we can develop this by recombinant DNA technology. So recombinant DNA technology was employed and we developed uricase recombinant, that was called RAS B uricase. RAS uricase was the first drug developed. It was a recombinant, as you can see R for recombinant. The enzyme is coming from birds, so B and uricase. RAS uricase was recombinant uricase which was developed. Now RAS uricase was given IV once a day, IV daily. Now giving IV daily was always a challenge, so further research, further development was done, and now we have been able to develop pegloticase. Pegloticase. PEG, any drug which has PEG written either in front or at the end, means the drug is pegylated. Polyethylene glycol, PEG stands for polyethylene glycol. It is an inert substance added to any molecule to make it longer or bigger in size. When the drug becomes bigger in size, its renal excretion decreases and that makes the drug longer acting. So pegloticase can be given IV again, the route will remain IV, but now the drug is given once in 2 weeks. Once in 2 weeks instead of daily. Pegloticase is the same drug as resbuticase, but it is much longer acting, and that is why it can be given once in 2 weeks. So this is what pegloticase and resbuticase is. Both are IV given drugs. Now when these drugs will be given? Coming to the indication of these drugs. Obviously the drug will be given in chronic gout. The drug will be given in chronic gout, but remember, even for chronic gout, the first line drug is allopurinol, which I have already told. So when in chronic gout, drugs like pegloticase will be used, it is only in severe resistant tophaceous gout. So that patient who is not responding completely or at all to allopurinol like drugs, then we think of these newer drugs like resbuticase or pegloticase. So these are drugs, number one, for chronic gout, not for acute gout. That is number 1 point. Even in chronic gout, these drugs are not first line drug, they are only for resistant tophaceous gout. So the option that is given in this question is chronic tophaceous gout. But it does not make it clear that whether this drug is a first line drug or second line drug or add-on. So please remember, pegloticase, recombinant uricase, IV given for chronic gout, add-on drug. It's not first line drug, it's an add-on drug for patients who are resistant or not responding completely to allopurinol like drugs. Question number 11, anti-glaucoma drug. That acts by increasing uveoscleral outflow. I think this is one of the simplest question that can be asked in pre-PG examination. So answer is very simple, latanoprost. So I'll just focus on drugs that increase some kind of outflow. So number 1, increase in UV outflow, uveoscleral outflow. The drugs are prostaglandin F2 alpha analogs. Latanoprost, bimatoprost, tefluprost, trovaprost, all prost, F2 alpha analogs, they increase uveoscleral outflow. The second type, drugs that increase trabecular outflow. I hope everybody remembers this also, miotics. So miotics like pilocarpine, physostigmine, ecothiophate, they increase trabecular outflow. So suppose the question asks instead of uveoscleral, suppose the question asks trabecular outflow, you are looking for miotic and there is no miotic given in the option, then which other drug? Do we have any other drug that can also increase trabecular outflow? Yes, nowadays do we have, and we have a new drug known as netarsudil. Netarsudil, any drug acting with sudil like fasudil, is a rho kinase inhibitor. So it's a new rho kinase inhibitor, topical drop, eye drop, which can also increase trabecular outflow. Okay, so this is the new drug netarsudil, increasing trabecular outflow. Third, you are asked that drugs that will increase both UV as well as trabecular outflow. Now what would be the answer if this question is asked? Drugs that increase both uveoscleral as well as trabecular outflow. So again we have a new drug that is known as latanoprostene bunod. Latanoprostene bunod, and again a new eye drop for treatment of glaucoma, latanoprostene bunod. As you understand, latanoprost, it's a prostaglandin analog. So any drug which has prostaglandin like property will increase UV outflow, uveoscleral outflow. And in bunod we have in the middle NO. So it has nitric oxide donating property and that increases the trabecular outflow. That would increase the trabecular outflow. So the question is pretty simple. In the form it has been asked that which increases uveoscleral outflow, latanoprost, no problem. But what are the more difficult question or more recent questions which can be asked? Increasing trabecular outflow, which new drug? Netarsudil, which is a rho kinase inhibitor. Which drug increases both the outflow? Latanoprostene bunod, which is a prostaglandin with nitric oxide donating property, and this can increase both uveo as well as the trabecular outflow. Moving ahead, question number 12. A patient diagnosed with rheumatoid arthritis was on medication. After 2 years, he developed blurring of vision. So in a patient of rheumatoid arthritis chronically taking medication, if there is complaint of something wrong with vision, answer is most likely chloroquine or hydroxychloroquine. And was found to have corneal opacity. Which of the drug is most likely? As I said, you even need not read the question, chloroquine, out of the given chloroquine. So what property or side effect is being asked? The side effect being asked is chloroquine induced retinopathy, which is also known as the other name bull's eye maculopathy. So chloroquine induced retinopathy or bullseye maculopathy. That is what we call the retinal damage caused by chloroquine. But please remember here, in a patient of rheumatoid arthritis, mostly we do not give chloroquine, we give its derivative known as hydroxychloroquine. So mostly the patient of rheumatoid arthritis receives hydroxychloroquine. So both are same drugs, only thing is hydroxychloroquine has less chances of causing this retinopathy, less chance, but it still can cause. So clinically a patient of rheumatoid arthritis will not receive chloroquine, he most likely receive hydroxychloroquine. So that is what you should know, there is some difference in their ability to cause retinopathy. But anyhow, whether it is chloroquine or hydroxychloroquine, both can cause retinopathy leading to problem with vision, which is what is being asked. What also has been asked, that what are the risk factors for this chloroquine or hydroxychloroquine induced retinopathy, and that you should very well remember. So what are the risk factors? So one by one I'll tell you. See, daily dose of hydroxychloroquine greater than 400 milligram is the risk factor for developing this retinopathy. Second, total dose that patient has received throughout his life, if that becomes greater than 250 gram, then that is also a problem. Total dose throughout his life. Then third, if the patient has already existing retinal disease, prior any retinal disease, patient has liver or kidney problem, patient has obesity, all these further increase the risk of developing chloroquine or hydroxychloroquine induced retinopathy. So coexisting retinal disease, coexisting liver or kidney problem, coexisting obesity. Then fourth, duration of use of chloroquine or hydroxychloroquine greater than 5 years is also a risk factor for chloroquine induced retinopathy. So although in our question the patient has received only for 2 years, so he may develop, but the risk significantly increases if the duration of chloroquine or hydroxychloroquine is greater than 5 years. So these are the important risk factors of chloroquine induced retinopathy, which also have been asked in previous All India examinations. Question number 13, a patient was started on fluphenazine. What is fluphenazine? I hope all of you can remember. Fluphenazine is a first generation antipsychotic. First generation antipsychotic, and first generation antipsychotic are simply D2 blocker drugs. Okay, fluphenazine. Few weeks later, he developed tremor, rigidity, bradykinesia and excessive salivation. First line of management. So what we have to understand, before going to management, we should know what problem has occurred. So this is also a very important topic based question, and that is extrapyramidal side effect of antipsychotic. So extrapyramidal side effects. First generation D2 blockers have problem of causing extrapyramidal side effects. So if the patients come within 1 week, less than 1 week, patient comes to you, he has taken fluphenazine for, let's say, for only 1 day, 2 day, that is less than 1 week, and he is having muscle spasm. He has developed spasm of muscle. Patient has developed acute muscle dystonia. Patient has developed acute muscle dystonia. Suppose he comes with torticollis, his neck has undergone spasm or his face muscle have undergone spasm, and he has been taking fluphenazine only for, not instead of few weeks, he has been taking only for 2 days, develop muscle spasm, acute muscle dystonia is the diagnosis, and the drug of choice to treat this condition would be centrally acting anticholinergic, CAC. Centrally acting anticholinergics. Now which drug should be remembered when we talk of centrally acting anticholinergics? Number 1, 3 B's are there. Anticholinergic is atropine, so remove A, add benz. Benz Benztropine is the first one. Benztropine. Then keep benz. Remove tropine, bring in hexol. Benzhexol. Benzhexol is also named by the second name trihexyphenidyl. So that is another name of the same drug, benzhexol. And the third B is biperidine. Biperidine. So these three are centrally acting anticholinergics. Any of them can be given and this spasm will go away in minutes. Now sometimes options are given and none of the option is these three drugs. So now you should also remember, and this is very very important, that antihistaminic H1 blockers which are first generation. So first generation antihistaminic, like three names are very very important and I'll write them here with green. Promethazine, hydroxyzine, and diphenhydramine. Diphenhydramine. These are three antihistaminics first generation, PHD, promethazine, hydroxyzine, diphenhydramine, which also have anticholinergic property, central anticholinergic property. So they also can be used as anticholinergics here, although the drugs are antihistaminic, but they have prominent anticholinergic property as well. So any of them can be used and this muscle dystonia will go away in minutes. Now if the patient presents in 1 to 4 weeks and he has become restless, he is moving about or constantly tapping his feet, he cannot sit ideally in his chair, patient has developed akathisia. And for treatment of akathisia, beta blockers are the preferred option. Beta blockers. If not treated by beta blockers, add anticholinergics. And the third problem, patient presents in 1 to 4 months. Patient has been taking fluphenazine for some months or more than, let's say, 4 to 5 weeks, and he presents with tremor, he presents with rigidity, he presents with bradykinesia. Tremor, rigidity, bradykinesia, the symptoms which our patient in this question has presenting with, patient has developed nothing but drug induced Parkinsonism. Patient has developed Parkinson's which has been drug induced by antipsychotic. And for treatment of this particular condition, drug of choice are again centrally acting anticholinergics, which I have told you. So that is what question is asking. What will you do? Patient has developed rigidity, bradykinesia, tremor. After few weeks of receiving an first generation antipsychotic, patient is nothing but drug induced Parkinson's, centrally anticholinergics, and these are the names that you need to remember, out of which, as you can see, option number B, trihexyphenidyl, is the answer to this question. Trihexyphenidyl. Moving on to the next question, which of the following drug acts by inhibiting DNA replication? We look at the options. We are given anti-cancer drugs. So this question has come from anti-cancer, very simple and straightforward question based on mechanism of action. Let's look at the option one by one. Asparaginase. Asparaginase, as the name suggests, is an enzyme which breaks down asparagine. So asparagine is a substance in our blood that is broken by this enzyme into aspartic acid plus glutamate. So it has got nothing to do with DNA replication. Actinomycin D and mitomycin, these two classes of drugs are nothing but anti-tumor antibiotics. Anti-tumor antibiotics, and anti-tumor antibiotics mainly damage the DNA strand. They damage the DNA strand by causing DNA chelation, forming DNA dimers, or forming abnormal base pairing within a already formed DNA. So they do not affect DNA synthesis, they damage an already formed DNA by forming two DNA come close, DNA dimer, DNA gets wrongly called DNA intercalation or abnormal base pairing. So we are left only with 6-mercaptopurine. 6-mercaptopurine. So the correct answer is option number A. What is this drug? This is an anti-metabolite. So anti-metabolites, they inhibit DNA synthesis, that is DNA replication, and that is why they are acting in S phase. S phase specific anti-cancer drugs. S phase specific. What are the drugs? Number one or type A, purine analogues. Purine analogues. They look like purines, so they insert in DNA synthesis instead of a normal purine and inhibit the DNA synthesis. Which are the molecules? 6-mercaptopurine, thioguanine. These are the two important molecules, 6-mercaptopurine, thioguanine, purine analogues. The second type of S specific is pyrimidine. Pyrimidine analogues. Which are the pyrimidines? We know cytosine. So first drug is cytosine arabinoside. Cytosine arabinoside, also known as cytarabine, and 5-fluorouracil. 5-fluorouracil. These are two important pyrimidine analogues. And the third type of S phase specific drug are DHFR, dihydrofolate reductase inhibitor. These drugs are, I hope everybody knows, methotrexate, the most important molecule of this class, and a newer member like pemitrexate. So methotrexate, pemitrexate, they are DHFR inhibitor. So these are three types of anti-cancer drugs which are S phase specific, and all of them will inhibit DNA replication. So answer to this question is 6-mercaptopurine, but instead of 6-mercaptopurine, any of these drugs can be provided. All of them will inhibit DNA synthesis. Question number 15, a patient on lithium therapy developed hypertension. Patient again on lithium therapy developing hypertension. He was on thiazide. I think there is no need to read this question further. This has been asked multiple times. Thiazides cause lithium toxicity. We all know, suggestive of lithium toxicity. What is the mechanism? So what is the mechanism? Answer is pretty simple. Answer is that thiazides, these drugs have a side effect of causing hyponatremia. They cause sodium loss. So hyponatremia is a side effect, a known side effect of thiazide. Now whenever hyponatremia would occur, what will kidney do? Whenever hyponatremia will occur, what is the kidney response? What will kidney do? Since the body has developed hyponatremia, the kidney will increase sodium reabsorption. So kidney increases sodium reabsorption from PCT, and along with sodium, lithium is also increasingly reabsorbed. Because kidney handles lithium like sodium. So whenever there is increase in sodium reabsorption from urine, lithium reabsorption would also increase, and that causes lithium toxicity. So this is a pretty standard and a highly repeated question. What we need to also remember here is that thiazides are the diuretic that most frequently or most commonly cause this interaction with lithium. So they should never be given with thiazide with lithium. Both should never be combined. But thiazides are not the only one. They cause it more than furosemide, which causes it more than potassium sparing diuretic. So the important thing here to remember is the hyponatremia. Hyponatremia is maximum with thiazide, more with thiazide than furosemide, and the more hyponatremia we have, more lithium reabsorption and more lithium toxicity will happen. So thiazides are the most frequent culprit. They should not be given with lithium because of this. But even furosemide is capable of causing, although less than thiazide, but it still can cause, and so can potassium sparing diuretic. So if tomorrow there is a question which says that thiazide, furosemide and potassium sparing diuretic all can cause lithium toxicity, answer is yes, they can cause. Which diuretic should be avoided with lithium? Ideally, all of them should be avoided. Which should be absolutely avoided? Thiazide. Furosemide and potassium sparing diuretic should be used with caution because they will cause much less incidences of toxicity, so they should be used with caution. So this is how you have to remember various sentences or various possibilities that can be asked tomorrow. The answer to the question I think is very simple. Thiazides increase the lithium tubular reabsorption. Question number 16. A patient developed pain and insect crawling like sensation on legs at night, which is relieved by shaking her legs. Which of the following is a drug of choice? So first of all, we have to make a diagnosis. The patient is suffering from what we call as restless leg syndrome. Restless leg syndrome. What happens in restless leg syndrome? There is creeping sensation. Creeping sensations in leg, abnormal creeping sensations relieved by movement, moving the leg, and worsened. This creeping sensation is worsened or increased by rest. So patient has abnormal creeping sensation in his or her leg, which is relieved by constant shaking or moving the leg and worsened by rest. So patient is always moving his legs, that's why the term restless leg syndrome, and it is mostly, the symptoms occur mostly in evening or night. So these are three principal features of this restless leg syndrome, and all three are given: insect crawling like creeping sensation, in legs at night, relieved by shaking her legs. So a classical presentation is given, diagnosis is very certain, restless leg syndrome. What are the drug of choice? Drug of choice are simply D2 agonist. D2 agonist, and which D2 agonist? We could have the non-ergot derivative D2 agonist like ropinirole, pramipexole and rotigotin. These are three non-ergot dopamine agonists which are mostly preferred as drug of choice for this condition. D2 is the word I have written, so mostly they should be D2 agonists. They should be acting primarily on D2 receptor. In this, it becomes important to mention that pramipexole is mostly a D3. It has more action on D3 receptor rather than D2, so this point may be asked. D3 agonist, while in general these drugs are dopamine or D2 agonist, ropinirole, pramipexole, rotigotin. So answer will be option number A. What are the other points? Rotigotin can be available as a transdermal patch also. The question has been asked some years before, not asked now because this patch has been discontinued in most of the countries, but still we may have a patch available in some countries. Most of the countries have discontinued this patch because there were crystal formation, but still this question may be asked. Second, why non-ergot? Why not ergot? Because non-ergot have less side effect than ergot. They are more safe. less nausea, less vomiting, less digital gangrene, so we prefer them. Okay, so they have less side effect, but no drug is without side effect. So what are the side effect of these types of drugs? What can be expected? Sedation. Daytime sedation is a possible side effect, especially with pramipexole, so that we have to be aware. Daytime sedation or somnolence can be a problem. Further, what are the other treatments of this restless leg syndrome? This restless leg syndrome can also be due to iron deficiency. So iron deficiency may also lead to restless leg syndrome. So iron supplementation should also be done. We should test the patient for iron deficiency anemia, and if found, then treat with oral iron supplement, and that is why you see option number D is also given, iron tablet. Now in the light of this, that restless leg syndrome can be treated by dopamine agonist or with iron tablet. Now if the question is asking drug of choice, answer is pretty clear, D2 or dopamine agonist. Suppose instead of drug of choice, the question asks which is the first thing to be done, first treatment to be given, not drug of choice but first treatment, answer would again remain the same, dopamine agonist. Try non-pharmacological therapy like sleep therapy and behavior kind of approaches. If not benefited, give dopamine agonist. Iron supplementation only to be done if patient found to have iron deficiency anemia. Otherwise, for this condition, whether it is drug of choice or first drug or the base drug, answer would remain as dopamine agonist. What is the problem with dopamine agonist? Sedation. Non-ergot dopamine agonist. Antiarrhythmic contraindicated in interstitial lung disease. I think very simple question again. Answer is amiodarone, because amiodarone causes pulmonary fibrosis. So the question is simply asking which drug causes pulmonary fibrosis. So there are many drugs which cause pulmonary fibrosis, and the simple mnemonic is BBC man. So all of us at one point or the other have watched this BBC news. So BBC man cause pulmonary fibrosis. This is how you'll remember. What does B stand for? B stand for bleomycin, anti-cancer drug bleomycin. Another anti-cancer drug known as busulfan. So bleomycin and busulfan. Okay, we have another B also, so I'll write busulfan here. C is another anti-cancer drug known as cyclophosphamide. So the first three BBC are anti-cancer drugs: bleomycin, busulfan and cyclophosphamide. M, we have methotrexate, another anti-cancer drug, methotrexate. Then we have a dopamine agonist or ergot derivative known as methysergide, which causes both pulmonary and retroperitoneal fibrosis. Both ways this question has been asked. A is the drug we are discussing, amiodarone, and N stands for nitrofurantoin. So these are the drugs that should be avoided in patient having pulmonary disease or interstitial lung disease, because all of them increase the risk of pulmonary fibrosis. Now, whenever there is pulmonary fibrosis, what other questions are asked? Number one, there is increased proliferation. There occurs proliferation of which kind of pneumocytes? Proliferation of type 2, T2 pneumocytes. So type 1 lung cells, pneumocytes are killed, and to make up for the loss, type 2, T2 of pneumocytes proliferate. So that we should know. Which lung function test or which pulmonary function test is the earliest indicator? So there is fall in diffusion lung capacity, decrease in diffusion lung capacity, and this is measured by carbon monoxide. So this is the earliest indicator, earliest pulmonary function test to go down in a patient of pulmonary fibrosis. So these are two other points that should be remembered in such kind of question. Any patient with interstitial lung disease, due to the risk of pulmonary fibrosis, all these drugs should be used with great caution, especially amiodarone. Question number 18, which of the following antimicrobials should not be given to a chronic asthmatic patient managed on theophylline. So the same paper we are having 2 questions on theophylline. So theophylline suddenly has become a very important topic for the subsequent examination. Theophylline. Theophylline has a narrow therapeutic index. Okay, it has a narrow therapeutic index. If its blood level increase beyond a certain limit, then it can cause toxicity. So first of all, what is that blood level? So 5 to 15 microgram per ml. We have to keep its blood level between this range 5 to 15 microgram per ml, preferably between 5 to 10. Okay, so we should in clinical practice try to keep its blood level between 5 to 10 microgram per ml, but in general the range is 5 to 15. Earlier this range was believed to be 10 to 20, and now we believe that a slightly less blood level would be more desirable. So if the blood level goes above, you are looking at toxicity, and toxicity of theophylline could result in seizure and arrhythmia, which are both possibly fatal. So we have to be cautious. So which things will increase theophylline level, which things will decrease theophylline level in blood, they should be known. So increased metabolism of theophylline, which would decrease the serum level. What are those conditions? Increased metabolism leading to fall in serum level, and that would wipe out its therapeutic effect. Number 1, enzyme inducer. So CYP inducer, drugs like barbiturate, rifampicin, phenytoin. These drugs will increase its metabolism, decrease its serum level, reduce its therapeutic effect. High protein diet. So metabolism increases with high protein diet. Smoking increases level. And 4th is children. I said smoking increases level, that was wrong. Smoking increases metabolism. So these are the 4 things that we have to be aware, that any drug that induces cytochrome like barbiturate, rifampicin, phenytoin, high protein diet, smoking and children, they all will increase the metabolism of theophylline, its serum level will fall and its action will decrease, so it will become ineffective. Drugs or conditions that will reduce its metabolism: increase the serum level and predispose to toxicity. And I said toxicity can result in seizure or arrhythmia, so we have to be cautious. What are those? CYP inhibitor. 3 inhibitors are something, 3 names are something that any student who is appearing for pre-PG should know. In fact, even a second MBBS student should remember. Erythromycin, ketoconazole, cimetidine. So these are very commonly asked and very potent CYP inhibitor. They will inhibit the metabolism, increase the level. Besides this, in case of theophylline also we need to know ciprofloxacin, and we also need to remember allopurinol. So all these drugs should be avoided sorry, with theophylline, because all of them will predispose to its toxicity. High carbohydrate diet. So high carbohydrate diet decreases metabolism, toxicity occurs. Elderly. So children metabolize it fast, elderly metabolize it slow. Liver disease reduces metabolism. Pneumonia. So patient of asthma also develops pneumonia. Metabolism of theophylline decreases, chances of toxicity go up, and CHF. So in all these diseases, metabolism decreases and chances of toxicity go up. So these are the conditions where metabolism either decreases leading to wiping out of the effect, or metabolism decreases leading to toxicity, and therefore we should avoid these situations or drugs with theophylline. Out of the given option, I think erythromycin is a very simple answer. Instead of erythromycin, tomorrow ciprofloxacin, cimetidine, ketoconazole, allopurinol, elderly, high carb diet, anything can be mentioned. We have to be cautious with theophylline. High altitude, patient complains of breathlessness. Why? Because he has developed acute mountain sickness. All can be used. So high altitude problems. There are three stages of this high altitude problem. Number one is known as acute mountain sickness. Acute mountain sickness, the patient usually complains of headache, dyspnea, along with nausea and vomiting. What is to be done? First, rapid descent. Patient should immediately start coming down. He should not ascend higher, he should immediately come down. Rapid descent is one of the most or the earliest thing to do. Ask the patient to descend down. He is not able to breathe properly, obviously oxygen inhalation, if available, has to be given. That is to be done in any case of dyspnea. There is no rocket science behind it. And acetazolamide. If you are asked drug of choice for this condition, acetazolamide. What acetazolamide will do? Acetazolamide will cause metabolic acidosis. Metabolic acidosis is a side effect of acetazolamide. This will be useful here. Why? Because at high mountain, sudden high ascent, patient has developed hyperventilation because there is less oxygen in the air, so is breathing faster. Hyperventilation. Hyperventilation leads to washout or giving out of too much CO2. So patient actually has developed respiratory alkalosis. That is the cause of this acute mountain sickness. So by producing metabolic acidosis, acetazolamide will counter the mountain sickness. So that is why acetazolamide is used. This is the first stage of high altitude problem, acute mountain sickness. Ask the patient to descend. He may not. He may continue to climb. He will enter the second step, which will result in high altitude cerebral edema. HACE. Now along with this earlier existing problem, he will also develop cerebral edema, and that would result in neurological symptoms like confusion. Okay, give him dexamethasone in addition to earlier existing treatment. Dexamethasone, if asked, will be drug of choice. Give him corticosteroids, particularly betamethasone or dexamethasone, because they have zero mineralocorticoid activity, so they will not retain any sodium. So dexamethasone or betamethasone are drug of choice. They will reduce the cerebral edema. If the patient still continues to ascend, he will end up in the final stage of high altitude pulmonary edema. High altitude pulmonary edema, his lungs will be filled with his own fluid. The water will come out of plasma and collect in his alveoli. So he'll start drowning in his own bodily fluid, high altitude pulmonary edema. And if you are asked drug of choice for this condition, then now we have to give calcium channel blockers like nifedipine. They will be considered drug of choice for this condition, nifedipine like calcium channel blockers. So there are three stages in which this altitude sickness presents. First is the less severe issue of acute mountain sickness, which is due to respiratory alkalosis. Acetazolamide is considered drug of choice along with rapid descent and oxygen inhalation. The next stage is high altitude cerebral edema. Give him corticosteroids with zero mineralocorticoid property like dexamethasone or betamethasone. And the last stage is pulmonary edema, and calcium channel blockers like nifedipine should be given along with the earlier treatment. So at high altitude, all can be used in the management. I think digoxin has no role in the treatment, it is useless. Rest of the points are to be done. Question number 20, true about non-competitive inhibition. Again, a very frequently asked question. So we have competitive antagonist or inhibition, and we have non-competitive antagonist. What are the points that are asked and what are the points that we should always remember? Number 1, competitive antagonist increases Km. What is Km? Km is the dose at which reaction achieves 50% of the speed. So dose at which 50% of the response is seen is Michaelis-Menten constant in pharmacology, Km. So it will increase that dose at which 50% of response is achieved. No effect on Vmax. Vmax is the maximum speed or the maximum response. So maximum response can still be achieved, but more dose will be required. How do we present it in a graph? So if we draw the dose response curve, this is dose in log form and this is response. So if drug is alone, this is drug alone. Suppose we have drug A. When present alone in your body, only drug A, this is the dose response curve seen, and the red line represents the DRC of the curve after adding X. So now the body has X also into the present into the body X. So what is X doing? X has caused a parallel rightward shift. So that is the second point we write, parallel right shift in the DRC. This graph has shifted parallelly to the right. That is the effect of competitive antagonist. How do we infer or how do we read this graph? Suppose this is the 50% response. 50% response. To get 50% response, earlier this dose, suppose this is 10 milligram dose of A was required. Now to get 50% of the response, we need 20 milligram or higher dose of A. So we are getting the response, but the dose required has increased. The maximum effect or the Vmax has remained same. So these are the two properties of competitive antagonist. Increase Km, that is the dose required, but no effect on Vmax. If we write in terms of potency and efficacy as the third point, then what we will write? Since it is increasing the dose to require the response, so it is decreasing the potency. Decreases the potency, but the Vmax is same, so efficacy remains same. So these are the three ways of writing the response of competitive antagonist. Number 1 way, increase Km, no effect on Vmax. Number 2 way, parallel rightward shift in DRC. And number 3, decrease in potency without any effect on efficacy. All three mean the same as I have shown in this graph. Non-competitive antagonist, first let's write what it does. So number 1, it will decrease Vmax and Km no effect. So Km will have no effect, but Vmax will decrease. Vmax, as I have shown you, is the maximum response or the efficacy. So we can say it will decrease efficacy. Efficacy will decrease. Km is the potency unchanged. And how will the graph look like? I will show you, but it will cause flattening or downward movement of DRC. Flattening of DRC. So if we were to draw the graph, so again we have the dose on the x-axis and response on the y-axis. The black line represents when drug A is alone in the body. This is drug A alone in the body. If X is added, then what happens? X causes downward shift. This is A plus X 1%. this is A plus X, let's say 5%, more concentration of X. More you add, more downward shift in the DRC occurred. That is what we have written, flattening or downward shift in the DRC. Earlier maximum response was, let's say 80%, now maximum response is less. The more X we add, the maximum response decreases. So Vmax is decreasing, efficacy is decreasing, flattening of DRC. So this is the three ways of asking the difference between competitive and non-competitive. Many times it has been asked. True about non-competitive. Km remains the same, Vmax decreases, option number A. So these are points that should be on tips of any serious aspirant of pre-PG, even undergraduate students. Question number 21, a boy is planning to travel by bus. Which of the following drug can be used to prevent motion sickness? It is a very simple question if we understand what are the mechanisms behind motion sickness. So there is a vomiting center in our brain. Vomiting center is in medulla. So please remember, vomiting is a reflex, and like all reflexes, the main center is in brainstem or medulla. For motion sickness, the impulse arises in the labyrinthine or the vestibular apparatus in the ear. From here, the impulse will travel to vomiting center. So this is the vestibular, or you can say labyrinthine apparatus in the ear, and from here impulse will go to medullary center and cause motion sickness. Now on this pathway going from ear to the vomiting center medulla, only two kind of receptors are present, either muscarinic receptor or histaminic receptor. No other receptor is present on this pathway. So this is very simple. You want to block this impulse, only two kind of drugs are available. Number one is a drug that is going to block this muscarinic receptor, or anticholinergics. Anticholinergic. Now which anticholinergic name comes to our mind? Number one, hyoscine, also known as scopolamine. Hyoscine or scopolamine, and this is believed to be the best drug for this disease. Hyoscine or scopolamine can be given orally, can be given as a transdermal patch applied behind pinna. This is considered the best drug. Which other anticholinergic, if hyoscine is not given in the option, you also look for dicycloamine. Dicycloamine is also another anticholinergic class of drug or antimuscarinic, which can be given if hyoscine is not given. Let's look at, for these two names, none of them is given. So then we have to look for the alternative therapy. Another kind of receptor, as I have shown you, is antihistaminic receptor. So we can think of blocking this histaminic receptor. So we are looking at antihistaminic. Now antihistaminics are divided into two generations, first generation and second generation. Now first generation have two properties that are useful in this condition. Number one, first generation can easily penetrate the blood-brain barrier because they are lipid soluble drugs. So their penetration across blood-brain barrier is more. They can easily penetrate, so they will act in CNS also. And secondly, they also have anti-muscarinic action. So although the drugs are antihistaminic, but they have anti-muscarinic action or anticholinergic action as well. So we want to block anti-muscarinic, they have this property. We want to do this action in CNS, they are lipid soluble. Addition of antihistaminic property will further benefit this condition, and all this we find in first generation antihistaminic. So if the choice is between first and second generation antihistaminic, then in motion sickness we will prefer first generation antihistaminic. So we are looking for names of some first generation antihistaminic. What are the names? Number one, look for promethazine. Look for diphenhydramine. Look for dimenhydrinate. There is some problem here. So promethazine, diphenhydramine, dimenhydrinate, and also you can look for a drug known as cyclizine. They are all first generation antihistaminic with high lipid solubility, blood brain barrier penetration, and also anti-muscarinic property. So they will be preferred over second generation because second generation do not have both of these property. So we look at the option and we find promethazine is given. So that will be the answer. Cetirizine, loratadine, fexofenadine, all are second generation antihistaminic. They can neither penetrate CNS very well, nor do they have anti-muscarinic properties, so they will not be useful or beneficial in the treatment of motion sickness. So motion sickness, hyoscine is the drug of choice. If not given, look for first generation antihistaminic like promethazine, diphenhydramine, dimenhydrinate, cyclizine. Which of the following antihypertensive drug is avoided in patient with high serum uric acid levels? Simple question again. Answer is thiazide. Thiazides cause hyperuricemia. They cause hyperuricemia. They also cause hyperglycemia, and they also cause hyperlipidemia. So these drugs should be avoided. They are not contraindicated. They should be better avoided in patients who have hypertension. HTN represents hypertension with. If patient has hypertension, along with hypertension he has gout, better to avoid thiazide. With hypertension, if patient has diabetes mellitus, better to avoid thiazide. And if with hypertension patient is suffering from dyslipidemia, it is better to avoid thiazide class of antihypertensive. So that is what question is asking. Which of the following antihypertensive is avoided in patient with high serum uric acid level? Answer is thiazide because of this property of hyperuricemia. Other options are also antihypertensive, so we should know what are the contraindications for this. Enalapril. Patient has hypertension with either pregnancy. So if there is a pregnant female with hypertension, do not give enalapril because they are teratogenic. And patient has hypertension because of bilateral renal artery stenosis. Avoid enalapril or ACE inhibitor because they will cause renal failure in such patients. They are contraindicated in these two disorders. Prazosin. Patient is a hypertensive with already problem of postural hypotension. Patient already suffers from postural hypotension, most likely elderly. This drug prazosin will worsen this problem, better to avoid. Atenolol. Now beta blockers have various contraindication, we will not go in each of their contraindication, but patient again hypertensive in pregnancy, avoid atenolol. This question was asked 2 years back also. Beta blockers as such are not avoided or contraindicated in hypertension pregnancy. Remember, labetalol is the drug of choice. But atenolol should be avoided in hypertension with pregnancy because of incidences of low birth weight babies. So it can cause low birth weight, and that is why it is better to avoid atenolol in a pregnant patient with hypertension. 23. Which of the following is a late inward sodium channel blocker? This is a fact based question. Answer is Renolzine. So we are looking at newer anti-anginal drugs. All 4 options are newer anti-anginal. So Renolzine is a, let's look at number 1, Renolzine. There is a late sodium current in heart. When this channel opens, when this current enters, it increases calcium entry also. So when sodium enters via this late sodium channel, it opens some other calcium channels also through which calcium enters, and when calcium enters, it will increase cardiac work, and work will increase, oxygen demand will go up. So if we inhibit, if we block this late sodium current, then we will be able to prevent increase in cardiac work. So Renolzine is used as a late sodium current blocker. The second drug is ivabradine. Now ivabradine is going to block the funny current. Now funny current is again a type of sodium channel, but this is now specific for SA node. Funny current. So current is denoted by I, symbol I, F, we use F, and since this is nothing but a type of sodium channel, this is how it is denoted, funny current, and ivabradine is blocking, so we can add a blocker sign to it. So it is a late, or not late, it is a funny current blocker in SA node. Now this current is responsible for diastolic depolarization or automaticity. Remember, SA node is able to generate impulse by its own. That property is known as automaticity. That automaticity is due to this current. So by blocking this current, it will decrease automaticity, and when impulse will not be generated in the same amount in SA node, this will decrease heart rate. So it's a bradycardic agent. Brady, the name, the spelling has brady. It's a bradycardic agent, decreases heart rate directly by acting on SA node. Ivabradine also used for angina. The third drug which is mentioned is trimetazidine. Trimetazidine, it is a inhibitor. It is an inhibitor of partial fatty acid oxidation. Fatty acid oxidation, the enzyme is LC3-CAT. 3-CAT stands for, LC stands for lecithin 3-ketoacyl transferase. This enzyme is inhibited. When this enzyme is inhibited, fatty oxidation is inhibited, and it will shift metabolism from fatty acid to glucose. So heart cell normally utilizes fatty acid. If we inhibit fatty acid oxidation, heart cell cannot utilize fatty acid, so it has to utilize glucose, and glucose needs less oxygen to burn. So oxygen requirement of the heart cell decreases by trimetazidine. So these are three drugs used for maintenance, not for acute but maintenance therapy of angina. Fasudil is also one of the drug which was in market for some time, mostly withdrawn, and any drug acting with sudil is a Rho kinase inhibitor. Rho kinase inhibitor. This was also, or we can say in theory at least, this is also possible to use this drug for chronic therapy of angina. So all drugs, all four options are oral drugs. They are for maintenance therapy of angina, but out of the four, Renolzine is the one which is a late sodium channel blocker. A person was given a muscle relaxant that competitively blocks nicotinic receptors. So we are looking at competitive or non-depolarizing muscle relaxant. Which of the following drug is used for reversal of muscle relaxation after surgery? So this is again a fact-based simple question. We have two kinds of muscle relaxant: depolarizing muscle relaxant and non-depolarizing muscle relaxant. Two kinds of muscle relaxant acting directly at NM junctions are available: depolarizing and non-depolarizing. Depolarizing are also known as non-competitive. non-competitive muscle relaxant. These drugs are actually not antagonist at all, they are agonist at the nicotinic receptor, while the non-depolarizing are competitive antagonist. Competitive antagonist. These are non-competitive antagonist. That is the first point. Example is succinylcholine, only depolarizing muscle relaxant. Example here are many, ranging from D-tubocurarine to various curiums like Atra, like Atracurium, to various curoniums like pancuronium. So curium, curonium all come under non-depolarizing or competitive antagonist at NN receptor. So all these drugs are muscle relaxant. Now what is to be remembered here? Succinylcholine has a very short duration of action. Its duration of action is roughly within 5 to 10 minutes. Okay, 5 to 10 minutes, it will not act more than that because it is metabolized by pseudocholinesterase in plasma. So no reversal is needed and no drug is available to reverse its effect because generally it is not needed. So no reversal is needed for which kind of muscle relaxant? Depolarizing muscle relaxant, that is succinylcholine, which is a non-competitive drug at NM receptor, nicotinic muscle type receptor. No reversal, no drug. Coming to non-depolarizing muscle relaxant or competitive antagonist at NM receptor, if the drug is longer acting like pancuronium, doxacurium, then we may need reversal. These drugs, reversal is needed. If you give overdose or if there is post-operative respiratory paralysis, we may need reversal. Now, which drug is given to reverse? Number 1, anticholine esterase. Anticholine esterase drugs, I hope you can recall, like neostigmine. They are given, they will inhibit acetylcholine esterase or true choline esterase in synapse. Level of acetylcholine will go up and acetylcholine will act on NM receptor, not the muscle relaxant. So that is the mechanism. So neostigmine like drugs can be used to reverse their effect. I think that is the answer to this question. What is more relevant nowadays is to remember that there is a new drug. There is a new drug known as Sugama Dex. Sugama Dex is a new drug which has come up and this will form chelate. It will chelate two drugs, that is rocuronium and vancuronium. So Sugama Dex is a new drug which can chelate the two muscle relaxant rocuronium and vancuronium which are present in blood and their effect will reduce. So it can reverse the effect of these two muscle relaxant rocuronium and vancuronium. So this is a new drug which will not produce the cholinergic side effects seen with neostigmine. So neostigmine will increase acetylcholine and acetylcholine can act on muscarinic receptor leading to muscarinic side effect. Sugama Dex will have no such problem. If there is reversal of rocuronium and vancuronium needed, we can simply give this Sugama Dex. It will simply chelate these two drugs. So the present form, the question is asked that there is a competitive muscle relaxant. Which of the following drug is used to reverse the effect? So in general, anticholinesterase like neostigmine are given. But if you are tomorrow specifically asked about rocuronium and vancuronium and a specific drug is asked, then Sugama Dex is a new drug available for that. For succinylcholine, which is a depolarizing or non-competitive, no reversal is needed and no drug is available. The last drug The last question, sorry. Drug of choice for invasive aspergillosis. It is a fact-based question. Voriconazole. Voriconazole is the drug of choice for invasive aspergillosis. So that is the answer to this particular question, option number B. So with this, we have finished all the questions that were asked from pharmacology based on the recall. The questions more or less were simple this time, unlike in AIMS where most of the points or most of the questions were based on recent developments. The questions asked in NEET were pretty straightforward, but as you can see, many questions have been asked, so you should revise the basic points and uh, just don't worry too much about examination. The questions, as you can see, mostly are based on simple basic principles. Thank you.